Okay. Good afternoon, everyone, and welcome to the American Urological Association's presentation on the 2023 CPT and Evaluation and Management Coding Update for Urology. My name is Ray Wiesig. I am the Director of Policy and Advocacy for the AUA, and I oversee our RUC, CPT, and physician reimbursement activities. I will be today's Master of Ceremonies, and before we get started, I have a few housekeeping items. And I can't advance my slide. There we go. Apologies for that. First, please note that the recording of this program will be shared in the AUA's Practice Managers Network online community, or PMN. The PMN has many benefits, including unlimited access to the coding hotline, access to the PMN private online community, discounts on education, and more. If you are not in the PMN and want to learn more, we invite you to visit auanet.org/PMN. Additionally, this webinar is meant to be interactive, and there will be time for Q&A at the end of the presentation. Please use the Q&A box at the bottom of your screen. We will do our best to get to each and every question in the order that they're received. If for whatever reason we're unable to answer a question live, we will follow up by email where possible. If you're experiencing technical difficulties, please contact Amanda Burns. Her email address is on the screen at aburns@auanet.org for assistance. And again, please remember that this webinar is being recorded if you miss something. And with that, it is my distinct pleasure to introduce our speaker today, Dr. Jonathan Rubenstein. Dr. Rubenstein is the chair of the Coding and Reimbursement Committee for the American Urological Association. He is a board-certified urologist with Chesapeake Urology Associates in Baltimore, Maryland, and the compliance officer for United Urology Group. He is the CPT advisor for the AUA and part of the Telehealth Task Force, the State Advocacy Committee, the New Technology and Imaging Committee, and Public Policy Council. He has represented the AUA at the ICD-10 coordination and maintenance meetings, and has been part of the AUA's Urological Allied Healthcare Professionals White Paper Ad Hoc Work Group, the Electronic Health Record Work Group, and the Telemedicine Work Group. Dr. Rubenstein grew up just outside of Seattle, Washington. He received his undergraduate degree from the University of California, San Diego. He received his MD from Baylor College of Medicine, his general surgery and urology training at Northwestern University Medical School, and completed a fellowship in endourology and laparoscopy at the University of California, San Francisco. And with that, I turn this webinar over to you, Dr. Rubenstein.
Great. So thanks, Ray. So welcome and thanks everybody for showing up today. You know, every year our CPT code set gets updated, and every year there are new codes that urology and those who help code for urologists need to learn. And this year, there's some pretty significant changes. So I'm really glad you're here on this webinar. I'm going to go over some new CPT codes that are both new and updated CPT codes. That there have been some moderate significant changes, especially in percutaneous nephrolithotomy. They really have to understand the details of it to make sure we code correctly. I also need to go over E&M codes. There's updates codes, especially when it comes to hospital E&M coding. So let's go ahead and get started. First slide. The slides can go. So we're going to be going over percutaneous nephrolithotomy codes, which are revised. They're different. The way we're going to code them after January 1st is going to change. We have a new code for laparoscopic simple subtotal prostatectomy. That's for benign conditions. It's different than our radical prostatectomies for cancer. There's new and revised codes for staple and suture removal if done outside of a global period. And there's some new category 3 codes that are emerging technology codes. So we'll go ahead and get to it. Next slide. So percutaneous nephrolithotomy, these codes have been revised and updated. Next slide. The reason that these codes need to be updated is that they were old codes, and really percutaneous nephrolithotomy transitioned really more from an inpatient site of service to an outpatient or ambulatory surgical site of service. Yes, can still be done in the hospital, but we're not keeping people in the hospital like we used to. Also, there was a lot of confusion with the terminology. It was not very granular. The word ureteroscopy, nobody knew if it meant antegrade ureteroscopy, retrograde ureteroscopy, was imaging included. And there are also some new interventional radiology codes that came into existence a few years ago. And one of our codes that we commonly use was removed. And therefore, how would these all fit in and what was overlap? There are things where urologists were not getting paid appropriately and things we may have been getting overpaid. Nonetheless, they needed to be revised. So they were revised. So starting January 1st, 2023, The nomenclature will be changing for these two codes. And we're going to talk about which codes can be used and cannot be used at the same time, what's included and not included. Next slide. So one thing that CPT made very clear is that the dilation, the access into the kidney is separate and billable work. CPT codes 50436 and 50437, which is for the dilation of a tract to be able to access inside a kidney to place endoscopic instruments, has a value. But that value was included in 50080 and 50081 previously, and there was a lot of overlap. Retrograde access can also be performed, but again, it was rather confusing on whether these could or could not be used. So breaking and removing stones is separate work from the dilation and access. And also complexity really wasn't captured by stone size alone. People have branching stones, stones in multiple locations, and ureter stones. These were not appropriately captured, and it was confusing on what code to use. So therefore, these codes, again, were revised, with 50080 being up to 2 centimeter stone in a single location, such as the kidney or renal pelvis. 50081 will be stones greater than 2 centimeters, or stones that are branching, or stones in multiple locations, such as the kidney, and stones in the ureter, or stones in the ureter, which is an increased level of complexity, or patients with complicated anatomy. Any of those patients, 50081 would be the correct code to use. Next slide. So because these change, we had to determine what is typically performed in these procedures and what is not typically performed in these procedures. And therefore, it is changing what is included in 50080 and 50081 and what's not included. So what is included is the work that's typically done, which is everything that's done antegrade. So whether we perform antegrade access into the kidneys, antegrade stone removal, antegrade ureteroscopy, antegrade stent placement, antegrade nephrostomy tube placement, that's all included. Also, with all new codes, radiologic supervision and interpretation will be included, like 50430, 50431, 74425. So if these are performed, do not report them separately from 50080 and 50081. However, what's not included, again, is the access and dilation into the kidney. So if one performs 50436, which is dilation of a previously established nephrostomy tract or wire, 50437, which is dilation with new access, 52334, which is the retrograde access, that's not included. Any retrograde work is not included, or open procedures that are performed concomitantly. So those can be reported separately if performed by the urologist.